Don't assume that you're just falling into your role into a functional system. You may be the entire system.
Experience saves lives. It's why we have to get as much experience as possible, because we know in those environments, no matter what, we're going to have to adapt. We're going to have to change.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care. Welcome to Frontline Surgery, Mastering Military Trauma Care. I'm Joshua Dilday, joined by my wonderful co-moderator, Matt Eckert. Matt, you want to say hello?
Hey, Josh. Hi, everyone. Thanks again for having me back and looking forward to this conversation.
Yeah, this is going to be a great episode. In this series, we help prepare early career military surgeons for the realities of deployed trauma care by sharing some lessons learned and some hard-earned wisdoms from those who have been there. Today's episode really focuses on exactly where this season is going, the top things I wish I knew before deployment. We're going to go over insights and practical advice that can make your first deployment smoother, your team more effective, or even just a repeat deployment better than the last one. We're joined by wonderful experts, legends in the field, actually. Jason Bingham, a seasoned former military trauma surgeon with multiple deployments, a leader in the trauma podcast realm, and none other than the legendary COL Jennifer Gurney, a senior leader who has guided surgical teams through multiple operational deployments, has led multiple initiatives of leadership, and currently is chief for the Joint Trauma Systems. COL Gurney, Dr. Bingham, you want to say hello for us? Thank you for joining us.
Thank you for the invitation. That was a way too kind and too grand of an introduction. I'm just an Army surgeon, like actually everyone here, and I really look forward to this discussion because what a great opportunity to, listen in the future and hear some of the hard-earned lessons to get better at what is the most important thing that we do, which is saving lives on the battlefield. So thank you so much for the invitation.
Yeah, thanks, Josh, Matt. Thanks for having us. I agree. You're way too kind. Just a simple community bariatric surgeon here. So you really, set the audience up for failure, but I'm hoping that they can glean something from it regardless.
We should have mentioned how humble they were as well. Well, thank you so much. Well, without further ado, let's get our experts talking about their field of expertise. Dr. Eckert, you want to kick off our scenario for us?
Sure. Well, Jen, Jason, thanks again. We frame each of these podcasts with a scenario to kind of help guide the conversation. So I'll begin with a clinical operational scenario for you to just kind of frame our discussion. And imagine that you've just landed in theater and it's your first deployment as a military trauma surgeon. Within hours, you're at your Roll 2 facility. You're unpacking, trying to figure out where things are and who's who, orienting yourself. And suddenly, the operations officer lets you know that there's a mass casualty alert. There's been an IED strike on a convoy. There's multiple U.S. and partner force casualties, and they're headed your way. Now, you've trained extensively as a surgeon, prepared yourself as best you can, but maybe not all the operational considerations, the logistics, the team dynamics, the pace, and the expectations of the unknown, unlike anything you experienced in residency or fellowship.
Now, COL Gurney, I'm sure you've been in this environment. I know you've been in this environment. Thinking back to your first deployment, what were the things you wish you had known before walking into this exact moment?
My team. I wish I had known my team. I think that's one of the risks that we have. We meet our teams many times on the way to deployment. And, or we'll spend a week with them in Miami, or we'll literally just show up and sometimes meet people for the first time. But that was me, actually, just a few months after residency. I'd actually just found out I'd passed my written boards. And then my deployment date was the next day. So at least I was, board eligible, right? And so knowing your team, knowing your limitations, and knowing how to communicate. Those mass COL scenarios, so my first deployment, we were split FST. We started in Tarankout, Afghanistan. I actually replaced an incredibly experienced surgeon who we high-fived on the flight line. And I just remember the feeling I had when he left, somebody with 10 years more experience than me, and knowing that it was a really busy place. And, we trained every day. So this 3 hours after you've landed and you don't know your team, you're really getting some risk with that, because you haven't had a chance to work a lot of things out. You haven't had a chance to open your equipment and be sure that you have things in your equipment. You haven't set up your OR table. That there is a lot of risk without having a team that has trained together. So what I wish I would know my team, man, I happened to find the book Top Knife like the week before I deployed, and I read it the entire flight out there. That is such a good book. I think it's a classic. And while we have emergency war surgery and some other things the thing about Top Knife is it gets you in the mindset. And a lot of this is the mindset, how you're going to approach each patient, how you're going to approach the majority of patients. And then also in a mass cal, you've got to know how to communicate, right? You've got to be able to communicate resourcing needs. You've got to be able to communicate evac. As the surgeon, and this is a surgeon podcast, so I can say this, right? But as a surgeon, you're the captain of the team. You might not be the commander, but there might be a CRNA that's the commander, but you are the captain of that team because in the end, how that team is organized, how they manage the resuscitation bay, timing to go to the OR, you've got to be able to communicate that. And then the other thing I'd say is just maintaining your situational awareness, which we don't always have to do in our civilian trauma centers or civilian hospitals, but you always have to do that about who else is coming in, what your resources are. So you've got to be able to communicate and be thinking about that all the time. And that's hard for for anybody, but especially for somebody who's right out of deployment. I don't know. Did I answer your question, Joshua? I probably went off on a million tangents and didn't answer a single thing that you asked, which is typical. So I'm sorry if I didn't answer it. But Jason will have a better answer.
I think that was great. Dr. Bingham, what do you think? I know you've been in this situation. Colonel Gurney mentioned multiple things. We don't know the team. The team dynamics are important. What are some other factors that first oh no moment becomes reality and things you wish you would have known then?
Well, I agree 100%. I think that's actually the most important is those soft skills. Like we do a lot of emphasis on the hard skills, damage control surgery. What do you do in this situation? What do you do in that situation? We drill that stuff all the time, but the soft skills of how to lead and integrate with the team and knowing what their strengths and what their weaknesses are. Yeah, it doesn't, your scenario is very appropriate. I don't have to imagine. I mean, I had that situation as well. Less than 30 days out from residency, I actually took my boards en route to, while I was at ATTD en route to my first deployment. And we took a drone, dropped a grenade on a mortar pit, and there was U.S. casualties on, if not the first day, the second day when we arrived in theater with a brand new team. So knowing that ahead of time, knowing your team ahead of time, really making the effort to contact them, learn who they are, especially if you're deploying with people that have been in the force comm world, they may not be clinically active. So they're scared and they're looking to you as the brand new grad that's less than 30 days out. And all of a sudden you're the captain of this team and they're looking to you. So knowing that ahead of time, as Colonel Gurney said, as much information as you can have about the operational environment. Every deployment is different, right? So you have different resources. You have different evacuation, patient movement. You have different resupply. You have different mission. You have different medical rules of engagement. You're seeing different injury patterns. Knowing as much of that stuff ahead of time and really putting the effort in. Deployments are disruptive as they are, so there tends to be this avoidance leading into it. But as much as you can lean into that ahead of time and contact the team that's on the ground and run through those scenarios in your head as much as possible, the better you can be. As I kind of mentioned, this isn't stuff I do every day. You kindly introduced me as a seasoned military trauma surgeon, but my day to day is hernias and bariatrics. So if I'm doing my job right, I'm not dealing with critically ill patients every day as you guys are. So that makes it even more challenging for people like me to be put in those situations. And it really requires that you put yourself in that mindset, as Colonel Gurney said, ahead of time, so that you don't freak out when this stuff happens.
And Jason, can I just say, or Joshua and Matt, can I say one other thing? I think we in the Army, but probably in the other services as well, do a massive disservice to our, individual surgeons and teams that deploy. We've been pushing, austere surgical team training for the better part of 10 years. And, we keep hearing things like there's no requirement for it. I feel like knocking on some 4-star's door and say, do you know we're deploying teams downrange that have never met each other before and have never trained together before? It's a huge disservice to us. But the biggest disservice is to who we're supporting, which is, every troop and every patient that, and every casualty that ends up on our OR table that we have not trained specifically for these austere, resource-limited, and challenging scenarios. I don't know who's going to be held accountable for that, and I know that's inflammatory, and I don't mean to sound inflammatory, but when I talk to senior leaders, they say there's no requirement. There's no requirement to train, and I've tried to explain the scenario that you gave, Joshua, this is a scenario. And I get people looking at me like, so a long way of saying is we do a big disservice for our surgeons and for our surgical teams, and ultimately for the people who we're supporting by not providing the right training to deploy. It's not good, in my opinion.
Amen. Hear, hear.
I think that's great. I think to your point about that, getting to know your team, I think it's thinking back to that first deployment. And there's this sort of hesitation. You want to project that you know what you're doing, and you realize that you don't want to ask a lot of questions. And then thinking back after many deployments later, realizing that probably most of those people were thinking the same thing. And nobody wanted to actually speak up and be the person to raise the hand and say, do we actually know how to do a walking blood bank? Do we actually know how we're going to handle a mass casualty? And having a little bit of humility and just saying, can I just ask a question because I'm unsure? And having the poor, E3 specialist explain it to you, which every surgeon doesn't want to do that, but actually probably needs enough humility to recognize they need to do that. Dr. Bingham, thinking about if you can remember back, because obviously it changes over deployments as your experience accumulates, but what do you think makes the difference in preparing for deployment so challenging for the military deployments? And that, we all moonlight at hospitals on the weekends. It's different in a rural hospital. It's different when you move to a different place. But there's probably some key differences that you've encountered and thought of along the way, and our listeners could benefit from.
Yeah, I think number one is don't assume that you're just kind of falling in to your role into a functional system. So you may be the entire system. Unfortunately, I think combatant commanders have a very poor understanding of what their capabilities are and what their limitations are. They expect you to just kind of take care of it and get things done. I have a surgical team, I'm covered, right? So things like, like we talked about the team dynamics, you may be deploying with people that are straight out of AIT that have never stepped foot in a hospital. Don't count on the fact that your 68 whiskeys or medics are going to be able to get access and transfuse blood. Don't count on the fact that your ICU nurse knows how to do a walking blood bank or run a Belmont. You have to know how to do everybody's job. That might be a little bit inflammatory to say, but again, this is intended to surgeons, so I think everybody's kind of been in that experience. You have to know how to set up the Belmont, how to run the Belmont, and train the team on it. You have to know how many amps it draws. Can you have a Belmont and a Bovie, or do you have to choose one based on the generator you have? I mean, these are things you never would imagine that you have to think about as a surgeon, but you do, unfortunately. Like I said, you're the entire system, so you can't count that you're walking into a plug and play type of environment. You're going to have to do things that aren't your job. You're going to have to, like I said, be the electrician. You have to be the OB. You have to be the urologist. You have to be the primary care doctor. So all that stuff I didn't really appreciate or anticipate. And your point is very well taken, Matt, that especially when you're junior, you're a little scared to admit that you don't know what the hell you're doing. But I promise you that pretty much nobody on the team knows what they're doing. So, the quicker you can kind of lose the ego and accept that and lean into it, you'll be much better off.
I want to highlight that last point, because this is the third time the theme of humility and soft skills, or what we kind of colloquially like to call these outside the tent skills, this fits into that framework. I find it interesting because the dogma of surgical care is you leave an expert. At least when you're a chief resident or coming in a fellowship, you feel this level of, I've made it, I've got the certificates, I've got the training. And then you mentioned that interesting point of, and then you have to have the humility of being taught how to use a system by an E3 and saying, I'm so used to saying, hand me X equipment. And they're saying, if X equipment is given to you, the entire tent shuts down. How do you even compartmentalize that decision-making when you have injured patients imminently coming at any minute? That just seems counterintuitive to everything we've been taught. And yet all three of you have mentioned that is a key component to things I wish I knew on that first deployment. How do you balance that?
Make no assumptions. I mean, all the stuff Jason talked about at the beginning, assumptions are the granddaddy of all. Choose your expletive, blank ups, in this type of thing. Make no assumptions and empower everybody to communicate, because it will be the E3 that sees something before you see it. Empower everybody to communicate. Put that ego aside. That is so important. Lack of communication and bad communication will kill patients on a small team. And if everybody doesn't feel empowered to say something, obviously going into it with the most skill you can possibly have, which is experience. Experience saves lives. experience saves lives. It's like why we have to get as much experience as possible, because we know in those environments, no matter what, we're going to have to adapt, we're going to have to change. There's going to be the things that we haven't seen and haven't trained for, just like Jason said. The other thing I'd say is there's some good things about that environment too. You're very patient focused. Yes, you've got to write your notes. Yes, you've got to communicate along the continuum of care, but all the things that kind of are the things that make you feel like are bang your head against, well, that doesn't exist in the deployed environment. You are focused on the mission and the mission only. And that downtime, and you do have it when you're not getting a lot of patients, if you're not training and everybody, like Jason said, everybody knowing how to run the walking blood bank and the silly bumblebee x-ray machine and how to do read a 9 line and how to communicate, up the chain of command. That redundancy of capability gives you an edge that you won't have if everybody's siloed in their thing. So no assumptions, empower communication at every level. So for people to say, anything that's wrong, get as much experience as you can and train the second you start hitting the ground on all of those key capabilities that will save lives, whether it's one casualty or multiple casualties.
Yeah, I'll say that having mentors, like for me, it was, I don't know if I thanked Dr. Eckert enough for everything he did preparing me for my first deployment. Dr. Huck, Ahmad Huck, if anybody knows Ahmad Huck, he's amazing. But the people that have been there and have done it and dealt with these things, it is helpful it's kind of that exposure therapy, right? To like, go to those FTXs that you really don't want to go to because they're clinically, disruptive. The ATOM courses, the live tissue training, the simulation events, and hearing, the stories of people that have gone through it before just kind of helps, prepare you for that. Having a good mentor, and there are fewer and fewer of people like Dr. Eckert and Dr. Gurney and Dr. Huck around these days who were around back in the day when things were busier. And I'll reiterate what Dr. Gurney said. There's a lot of good things about when you're in a high off tempo environment with a small team. Towards the end of one of my deployments, I said I would much rather get shot on the doorsteps of the FRSD than in my hospital back home, because you can get them in the OR, you can get blood transfusion, you can get them stabilized a lot easier than waiting for them to scan the patient into the system and create the electronic medical record before they release the blood products. So there are good things to all that getting cut out, but it can be painful to get there.
Absolutely. So lack of communication is deadly. Experience saves lives. Mentorship is key. And mentorship is quickly going away. And I think that's really one of the points of this podcast is this is an opportunity for us to diminish that Walker dip. Like you said, I mean, Matt Eckert, Jason Bingham, both of which are no longer in the military. Colonel Gurney has already had an illustrious career, but obviously you can't stay in forever. So where does that mentorship continue? That's why this podcast, we want to make sure that we get all of those voices heard now, because who knows what that mentorship is going to look like, and we're definitely going to need it. And all three of you have had multiple deployment experiences across a wide array of operational spectrums. You've spoken about some of these kind of lessons learned, but what are some of those lessons, and what helped you the most on that second deployment or that third deployment? Really kind of frame some common pitfalls that you hit that you're like, man, I don't want to do that again. And then how can we gain your experience now without having to duplicate some of the same key mistakes you've seen others make in the field?
What helped me on the second one is, it's interesting. The ones I've had several deployments. Some of them have been busy, and some of them we didn't do anything. And thinking back on it, the ones that actually were the scariest were the ones we didn't do anything. Because you're walking into a place that hasn't seen a casualty for 6 months or a year. I think it's really important, as Dr. Gurney said, don't assume anything. Everything on the shelf might be expired. You have no idea how to evacuate a patient. The whole system doesn't have any reps. Those are the ones that actually made me the most nervous. Were the ones where I was walking into some place that wasn't busy. Those are the scary places in my mind. So don't assume anything. To be able to communicate up is really important. And that's something we don't really teach enough, those soft skills of like being able to go to the base commander and say, hey, this is messed up, man. If somebody really got injured here, we'd be in a really bad spot. And being able to communicate at that level, briefing commanders and that type of stuff, that's extremely important. And those soft skills, again, we focus a lot on the hard skills, but the soft skills matter a lot. So I can go through like kind of what my pre-deployment, kind of checklist is. Dr. Gurney already mentioned some of those things. Number one, I read Top Knife 2 or 3 times. I take a physical copy with me. I read it on the plane. I read it during my downtime on deployment. those ATOM courses, those live tissue trainings, those are really important. Learning how to take inexperienced members of your team, take the scrub tech out of the field hospital or out of the FRSD, with you to those things and getting practice, working on that, run scenarios. Asset, I become an asset instructor. And when there's an opening in the asset course or the asset plus course, take it as a student and continue to teach it. Because for me, again, I'm a minimally invasive guy. So learning how to do vascular exposures is not something I do every day. So as much exposure to that. I'll put in a plug for frontline surgery. Dr. Eckert and Dr. Martin, that book is extremely helpful. So it's big, it's heavy, but I take it with me on my bags when I deploy. Reading the CPGs, the JTS CPGs, familiarize yourself with those. They're great. You should read them ahead of time. And then the thought exercises. So Colonel Gurney mentioned getting yourself in the mindset. So the War Surgery in Afghanistan and Iraq book it's a little bit dated, right? It's not going to really, it's a different operational environment, different injuries, different things. But reading through those cases and trying to go through those thought exercises about how would you manage that case in different environments is really useful. The JTS conference, put in a plug for that. If you can listen to that's a good way of getting plugged in and learning what's going on and how others are doing things. Again, participate in the FTXs, even though it's a pain in the ass. It's always inconvenient. You never really want to do it, but it is extremely helpful. And then engaging your mentors and learning from them and asking questions and asking to hear their war stories, because you'll find yourself in some very similar situations. So that's my mental checklist that I go through when I'm preparing for a deployment.
Jason, you're really good at this. Yeah, like I was like, "Oh, man, I'm glad this is a podcast. Maybe I'll listen to it." No, you're everything you said. I like totally agree with. And thanks for saying the stuff about the JTS. We do work really, really hard to keep the CPGs updated. Got a lot of people working hard to be sure they're updated. And that call, the call is reflecting on what's happening all the time and putting yourself in the mindset of those cases and those drills downrange and like kind of almost like you do those action drills like in the military, like on the range. Do those for cases too. Test the whole team on the scenarios. One thing I always carry with me after my first deployment, a really, really, really good headlight. Man, you never want to be operating without a really good headlight. I always think that's one of the things I hand carry with me. I want to say something that I kind of just elaborate on something that you said. You made a comment about the low deployments, and you made two comments, and I'm going to tell a quick story that addresses those comments and really kind of demonstrates some of the risks that we have as military surgeons. And you said these low tempo deployments are, the ones you worry about because the team is not ready to go because it's not getting their reps every day. When I was the trauma medical director in OIR, we were busy and we were seeing host nationals. We actually saw a clinic. Well, Jason, I replaced you on that one. Remember we had that clinic across the way and we were constantly getting patients. We had patients in the OR, like, not always big cases, but we had cases every day. And now there was this team in Kuwait that was sitting down there like doing nothing. So I made the argument to do rotations, to bring the guys from Kuwait up to where we were in Baghdad, to give them a chance to be in an operational multinational environment with, live ranges and working with partner force and everything. So I go down and, it's just going to be gone. And the DCCS said to me, "What are you talking about? Like, we have the most ready team in theater. They're doing absolutely nothing. They're going to the gym twice a day. They're eating, they're sleeping. There's nobody more ready than our OR teams because they're doing absolutely nothing." And I was like, is this a joke? And so that mentality of like the team is ready because they're rested, the team is ready because they're doing nothing is a little bit pervasive. So you mentioned the risk of these low tempo deployments. And you also said that people don't want to say that there's a problem. But you said that, people don't want to say to whoever the commander say, "We've got a problem here. Like, we're not ready. We're not ready. Like, we might have our stuff here. We might not have our stuff." But I think that articulating that risk is important. And then trying to find ways, whether it's whatever it is, to mitigate that as much as possible. But both those things are kind of exemplified in that story. We have got medical leaders who don't understand the risk of not doing anything, and then we have the same kind of people who don't want to say to their bosses like, "Hey, we're kind of screwed if we get really busy." And, so much we did have these low tempo deployments sometimes, and people would equate like tactical success with clinical success, because that'd be the other things. We'd move around and we'd get out on helicopters and we'd go out on C-130s, and we wouldn't necessarily take care of a lot of patients, but we'd move, we'd pack bags, we'd do all this stuff. And then they'd say, "Oh, it's a success." It's like, tactical success isn't the same as clinical success. And I think, in the end, where we win is when we save lives, when we preserve the strength of the force by saving lives, as many lives as possible. And we give these guys confidence to do these really high risk jobs because of that. But if we're not clinically ready, we're not ready. And people don't want to always admit that. I think that we have a lot of communication challenges in our own ranks about what readiness and what risk is for the operational environment.
Well
Wow.
said.
If we're not clinically ready, we're not ready. And being rested is important, but does not equate to readiness. That's key. Dr. Bingham, I mean, you summed that up perfectly. You summed up our entire episode and just laying out your pre-deployment checklist. I think that should be standard listening for everyone. I know that took care of that. That was great. I mean, that summed up exactly
I
what we were
learned a few
looking
of
for.
those things the hard way.
There you go. That's exactly what it's for. Experience is a phenomenal teacher. It just doesn't necessarily be our experience. It has to be the teaching. This is why this podcast exists. And this is why we've invited both of you on as experts to really be one of the key kickoff episodes for the season.
Well, I think it's really important you're doing this. So I commend both of you. I think it's extremely important to canonize all of our experiences because, like I said, there's fewer and fewer of those gray hairs walking around. So thank you for everything you're doing.
Agree.
Well, Dr. Gurney, Dr. Bingham, this has been fantastic. We really appreciate your insight and contributions to the podcast series. I know that the young surgeons out there now and in the future are going to listen to this and benefit from this and help guide them in the right direction. So thanks again for joining us on Frontline Surgery, Mastering Military Trauma Care. We know that deployments are intense, but preparation and shared wisdom can make the difference between surviving and thriving or failure as a military trauma surgeon. We hope you've enjoyed today's conversation and it helps you prepare for your next deployment with confidence and perspective. Until next time, stay sharp, stay ready.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield ready knowledge. Until then, stay ready.